Hi everybody, this is Dr. Parsons, and today I'm going to go over a very pediatric liver entity called biliary atresia. So what is biliary atresia? Biliary atresia, and specifically the type we're talking about today, extrahepatic biliary atresia, is essentially just the obliteration or an area of discontinuity of the biliary system that leads to an obstruction of bile flow out of the liver. So what happens is all of that bile accumulates within the hepatocytes. Bile is very toxic to hepatocytes, and so then you start to have cellular injury, regeneration, more cell death, more fibrosis, and ultimately the end game of this, unfortunately, is cirrhosis for these patients. There's some surgical interventions that can be done. We'll talk about that in just a minute. But there is a significant proportion of these children that ultimately go on to require liver transplantation. When you're looking up the history for these kiddos, you'll find that they have presented with jaundice, and they have jaundice outside of that normal physiologic jaundice of the newborn time frame. That shouldn't be persisting over months, or really even over several weeks. The other thing that you will find, specifically with respect to laboratory values, is that their conjugated bilirubin is going to be elevated. So we kind of expect babies to have unconjugated hyperbilirubinemia. And part of that is just due to the fact that their livers are not mature enough to really be able to fully process bile. So their little liver enzymes are not quite ready to keep up with how much bile they have to conjugate. However, when you have a problem with conjugated hyperbilirubinemia, that implies that you don't have a functional problem within the hepatocytes. You have some sort of a mechanical problem. You've been able to process that bile, but now you can't get it anywhere. So that's why these patients present with that specific type of conjugated hyperbilirubinemia. Other things that you will find in the medical record that are helpful to know are that the patients develop pale stools. Sometimes they'll have normal stools for a little while, and then they turn kind of this pale yellow or clay colored, I've often read it described as. And sometimes these babies will also present with dark urine. So just a quick review of the structures that we're talking about, because again, we're talking about extrahepatic biliary atresia, and it affects really all these various components of the extrahepatic biliary system. So we've got our left hepatic duct and our right hepatic duct that are joining together to form the common hepatic duct. We've got our gallbladder over here with its cystic duct connecting into the common hepatic duct, going all the way down to our common bile duct. So as you can see from this depiction, that one of our surgeons loaned us, extrahepatic biliary atresia can really occur at any point in the biliary tree. You can have it isolated to the common bile duct or to the common hepatic duct, or it can really involve all the various components, even going up into the porta hepatis where those left and right bile ducts form. So this is an example of what a gross specimen looks like when surgeons will assess these children. So kind of the normal course is the patient will have a biopsy, like a core needle biopsy of their liver. We as pathologists will evaluate it, and we will say that the features either support or don't support biliary atresia. The patients will often undergo cholangiogram to try and identify the biliary tree, and that can be really helpful because then you can see areas of obstruction, or you can not see components of the biliary tree. And I think that is obviously another helpful finding in making this diagnosis, because it really is kind of a clinical multidisciplinary diagnosis up until the time when the surgeon starts to intervene. Other things that can be salient are you may find that there will be imaging, usually ultrasound, that can't identify a gallbladder. That's another really strong supporter of the fact that this might be biliary atresia. So in this particular specimen, what's been done is a portion of the liver has been shaved off. This is the portal plate where those bile ducts, where those the ducts combine to form the common hepatic duct. Here's the gallbladder. It's really, really skinny. This is really tiny. And then you can see here, hopefully, that the common hepatic duct is really, really thin. Now, if we were going to serially section through this, we would most likely find just kind of an obliterate, like a cord of fibrous tissue. We wouldn't be able to find a lumen. And that, ladies and gentlemen, is biliary atresia. So you can see you would get backup of bile here. Liver would not be able to get that bile going anywhere past this point, and that's where you get that hepatotoxicity. So one of the interventions that they can do for these patients, really the only intervention outside of liver transplant, is what's called the Kasai procedure. And some of you may have seen this if you rotated on pediatric surgery in medical school. But essentially what they do in this procedure is they take a portion of small intestine and they remove it from the duodenum, and they take that portion of small intestine and they just sew it right onto the portal plate. And what this does is it facilitates the flow of bile out of the liver, gets it into the small intestine where it would ultimately be going anyway. And now you've got some free flow of bile and you can give those hepatocytes a break. Then, as you can see, they just kind of hook up the duodenum a little bit distally and everything works great. Well, that's not entirely true. These procedures do have a variable failure rate. And one of the most important things that I tell our clinical colleagues that are in training is that these babies really need to be identified and undergo intervention, i.e. Kasai, before 60 days. A lot of different studies have shown that the success rates of the Kasai procedure drop off dramatically once you hit 60 days. So that is a very, very important thing from a clinical perspective. So now we're going to take a quick look at what the salient features of biliary atresia are under the microscope. And I think this is a good time to point out that while we can certainly favor biliary atresia, there are other causes for the findings that we're going to discuss. So typically when I do my reports, I will say a descriptive diagnosis and then say, in the appropriate clinical context, these findings would be supportive of a diagnosis of biliary atresia. And I personally like to have a conversation with the hepatologist as well as with the surgical team to try to get a sense of what their impression is too, because it's not cool to try to work in a vacuum. So now we're just going to go over what we see histologically in the context of biliary atresia, just so that you're aware of some of the key features. And there aren't too many, but they are pretty important. So just kind of a low power overview. Now, this is not the type of specimen that we typically get first on these babies. Typically, we will get a core needle biopsy first for evaluation. This is the portal plate, the portion of the liver that was removed at the time of a Kasai procedure. And I selected that today because I think that it does an excellent job of really highlighting the most dramatic process in this particular disease. So super duper low power, but hopefully you can appreciate that this is a portal tract, and this is a portal tract, and this is a portal tract here. And we've got all our intervening hepatocytes here. Now, I gotta say, to my eye, as I'm looking at this, it looks a little bit nodular to me, which is not something that is super great when we're looking at livers. This is kind of one nodular area that I can appreciate. Here's another one. This looks like it's going to be another one here. So Let's go ahead and start by taking a look at the hepatocytes themselves. Get on a little bit higher power here. So here are hepatocytes. And one of the things that I will draw to your attention right away are these brownish yellow things. So this is what bile looks like histologically. You may have seen it in some of your liver cases if you've rotated on liver already, over there on the adult side. But this is what bile plugs look like. Now, there's a couple of other interesting things that are happening here. One, I think we've got some cells that are on the way out and dying as a result of injury. The other thing is, can you see how this is kind of circling up? It's almost making sort of a pseudoglandular structure. Now, saying that in the adult liver world is scary because that starts to imply things like hepatocellular carcinoma. Not happening here. That's not what this is. What's happening here, though, is these hepatocytes appear to be trying to transform into bile ductular epithelium. Fascinating thing that the liver can do. We're going to scoot down over here to this portal tract. And what I'd like to draw your attention to is the fact that there are a whole lot of bile ducts, or kind of primitive looking bile ducts here. I see one here, possibly here, 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 there, in there, probably the one that belongs there. This guy here, this one here, some of these guys are kind of in transition. They probably used to be hepatocytes like these. These look like they're kind of trying to transition into a bile duct too. Holy smokes, that's a lot of bile ducts and what we call bile ductules. Here, over here, is another one of those bile plugs, kind of like we saw out in the middle of the liver parenchyma. Now, in biliary atresia, we often see bile plugs within bile ducts. And that is one feature that can be kind of helpful in making you think, yeah, this really might be what's happening. But the true salient feature here that is of utmost importance is this bile ductular proliferation. Now we're looking at a different area, a different portal tract. So we've got our arteries, we've got our vein, but then we've got bile duct after bile duct after bile duct after bile duct, and so on, and so on, and so on. Now, you don't always necessarily have the components of the portal triad like in perfect similar quantities, but this is way too many bile ducts for a normal portal tract. So the reason that we see this bile ductular proliferation goes back to the pathophysiology of this disease process. Because you might be saying to yourself, Parsons, you just spent like 10 minutes telling me that the way this disease works is the bile ducts scar down. Well, remember that this is extrahepatic biliary atresia. So you've got your disruption of the biliary tree further downstream from the liver. So what's happening is the liver is trying to drain its bile. It's getting stopped up somewhere, let's say in the common hepatic duct. All of that bile is going to build up backwards, and it's going to build up in the liver. And the liver does not like having excess bile. It's toxic. So what the liver does is it attempts to make more bile ducts within the liver to try and drain as much bile as humanly possible. Because it's like, well, maybe if I make a whole lot more bile ducts, I'll have more bile ducts to get more bile out. Problem is that the issue is downstream from that. And so that's why we see this bile ductular proliferation in the context of biliary atresia. Now, if you did not buy what I'm selling as far as this bile ductular proliferation, one of the things that you can do is you can look at a cytokeratin 7 immunohistochemical stain, because that's an immunostain that's going to highlight bile ducts and bile ductules. So cells that are transforming, hepatocytes that are transforming into bile ducts. We're going to scooch ourselves to a lower power here because I think that will more effectively show you just how many bile ducts and bile ductules there are in these areas. So the cytokeratin 7 is pretty dramatic in a lot of these, and this is all bile ducts and bile ductules. So way too many for any one given portal tract. So this does an excellent job of highlighting what is really one of the key histologic features of being able to support a clinical diagnosis of biliary atresia, is this bile ductular proliferation. So I hope that you maybe learned something today, and I hope that made sense. And if you have questions about this disease entity or anything was unclear, you can feel free to shoot me an email. Hope you guys are staying safe and staying well. I miss you lots, and I will talk to you soon.